Tatyarao Lahane sir. As we all know that he has done a large number of cataracts, and you know, with the advent of phaco machines and good affordable phaco machines and affordable lenses, we had patients of all walks of life walking to us. But even in today's day, and especially after COVID, there was for 1 or 2 years a surge of cataracts which were hyper-mature or Morgagnian, and it could be still done, which is what sir will be showing us.
Good afternoon, everybody. Thank you, Ragini, Siris, and
so sir has been a teacher to all three of us.
And thank you, everybody, for supporting me for the election also. See, when you are considering the white cataract, so in that there are some challenges, and challenges are the absence of the fundal glow, extension of the rhexis, then the posterior capsular rupture, nucleus drop, the endothelial damage, and then lastly the lens is decentrated. So then use the trypan blue when you are operating. Then the extension, use the forceps, or you can, if you are unable to do that, then change it to the can opener and go for SICS. Then the posterior vitrectomy, if it is there, then you will have to go with the 3-piece IOL with the iris claw. Nuclear drop, call your friend. The visco, to avoid the endothelial damage, use visco minimum twice when you are operating. And when there is a decentered IOL, rotate, but don't rotate on second day, wait for 2 weeks and then rotate. So now this is the case, and you can see the white cataract, which is you can see in the center there is a fibrosis seen. Now when there is a fibrosis in the center and you have stained and operating, so now see I am going in the mid periphery. So don't can say open in the center, because in the center the force of the fluid is much more and you get the Argentinian flap. Now see I am doing with the needle. When I am doing with the needle, so that goes in the periphery. So now I am doing with the forceps, so control is much more. So but here I am just recatching and recatching, not doing in a one go. Still see here now, I have recast, still it has gone in the periphery, because the fibrosis of the capsule was there, and so it has gone there. So now you can see the nucleus is saluting. It means once you are doing this, see here, so now there is no buttress, and so whenever you are doing, so you will have to chop. How? See here, this is a sandwich like thing. It means nothing is there, so you will have to see the tip and the chop. So my chopper is a non-sharp at the tip, see here, and then I am removing this. As you know, this again you will see the chop, this tip here, see tip slightly downward and then sandwich in between two. So once you sandwich in between two, that is called as a horizontal chop, and in that you can definitely make the pieces when there is no support. When last piece is there, here we are always in the, can say, flight, in the phaco means flight, and so you go fast, and that tears the PC. So phaco is not a fast procedure, but phaco is a safe procedure. So don't go fast in phaco. Now see here, you can see the fluid. You can see the fluid here, and once you see the fluid, then you must know how to go ahead to do the rhexis. See here. So if you are going in the, can you see I am going in the slightly peripheral part, can you see this? Not in the center. Open I have done in the peripheral part, and then doing the rhexis. So whenever I am doing the rhexis, you should be very conscious, because if the rhexis is not complete, then you can't do the phaco. Again you will see I am trying to do the rhexis here, again you will see I am trying to do the rhexis, but not happening. So what I did, I took a forceps, and you will see there is a eccentric rhexis, not in the center. After doing phaco, you can do, if you want, in the this one, and here you will see it was seen like white, but behind that white fluid there is a yellowish brown cataract. It means it is a harder one. And so now I am here using the sharp chopper. You see this, I am doing the trench, but as there is no support, so trench is not happening. So again you will see this, I have separated, and whenever you are separating, keep it up to the center. Now when the phaco tip is going, it should go slightly down, not straight. If your phaco tip is going straight, you can't do phaco emulsification. So always remember, see here, tip slightly slanting down. When that is a slanting down, it will enter in the substance of the nucleus. It may be very hard nucleus. So that is a stroke length, see here. And once that enters inside, I always see here, again see, my phaco tip, see, it is not horizontal, it is slightly slanting, can you see this? And then I am making the pieces. So it means my phaco tip is buried inside the nuclear substance, and this is a hard substance, so it remains inside. It is not a soft. So it remains inside, and then that you act as a support. So that will support your chopper, and once that will support your chopper, then you can do it. See here. Now you have completed the case. Now again you will see the another case. You will see here. Once you see the case, it is a, you can say, milky white. It means this cataract is a soft cataract. It is not an, can say, but this fluid occludes, see here, it occludes your vision whenever you are doing the rhexis. And there you have always a problem. So wait and aspirate the fluid. Aspirate the fluid. So once you aspirate and then use the forceps. So what happens, we never aspirate it, and because of that the problem comes. See here. So I aspirated and came out, and after that, see, I am doing the phaco emulsification. See here, the nucleus you will see it is moving because no support. So again what I am doing is, can you see this? I am supporting it with the phaco tip. So here, the embedding the phaco tip in the substance, see here, of the nucleus and chopping. So once again you will see, embed it and chop it, horizontal chopping, or you can modify it horizontal to vertical, say again, and then separate it. It means the nucleus here you will not use the support of PC. If you use the support of PC, then that will tear definitely. And so nucleus should be above the PC, above the PC. And once it is there, then you can definitely do it. See here the another hypermature cataract, you will see here, I am doing the rhexis by the forceps. Can you see this? So again see here, the rhexis, what I have done is, I have done in the center. Now once I have done in the center, then that flap which is in the center, that will extend, and you will get the Argentinian flap. Why it has happened? Because I was not concentrating. And then I will try to do, catch this and catch that. Don't do that. Cut it. I have cut it, and again I have cut it. Now I am doing the phaco. You just see the flap near my chopper. It is called as flap. It is called as flap rotating sign. That motility sign of the flap. See here, it is a Rohit. He is on phone also here asking me to come there. So here you will see that motility sign. Always remember, if that flap is moving, go for phaco. If that flap is not moving, don't go for phaco. It means you have teared the PC. So whenever you are doing, look, you must see the flap moving, flap moving. If that flap is not moving, stop, because you have teared the PC. So instead of inviting the retina surgeon, you yourself control yourself. If you control, then there is no problem. So phaco is complete because of the anterior flap motility sign. If that sign is absent, don't go for phaco. If that sign is present, go for phaco, and otherwise you, now this is the, what I want to tell. see the sleeve. See the sleeve of the, you can say this sleeve. It is a transparent sleeve. The same surgeon, this is me only. And see, I told you to go down. The tip of my phaco is down, not penetrating inside. I am trying to penetrate, but not penetrating. Can you see? No buttress, no support, and I am penetrating inside. What is happening? It is not penetrating inside. See here. And I am trying to remove that. Okay, I am going to do phaco. You know this is a white cataract, and see it is moving. Now once the cataract is moving and you are operating, what will happen? How many, see here, how many circles that is taking, so many things happens in the ventricle of your heart. So you will get the flutter. So this flutter, see here, this flutter, can you see the flutter? Flutter. Your age is reduced by 1 month. 100% age is reduced. So SICS is better than phaco. So in such cases, don't take such type of risk that I am a phaco surgeon. No. So don't do that. Now see here, this sleeve is changed. Can you see this sleeve? It is white. Another phaco. Another phaco. So why it was not happened? Stroke length of that phaco was less. And because of that, it was not penetrating inside the substance of the nucleus. And so whenever you are purchasing, you must know the, you can say the stroke length. See here now again, only I want to see you, the tip is slightly downward and it enters in the substance, and once it enters in the substance, then only we can do such type of phacoemulsification. Can you see this? And the last piece, you must remember, if this is the last piece, you should not do it fast. Otherwise what happens? We have completed the, you can say phaco, and then you feel, yes, I have completed the phaco, and then you will go ahead and so the okay. Now you see the when I am doing the phacoemulsification, can you see this? And it is a brownish in color. So when it is a brownish in color, see my chopper. When my chopper is going in the periphery, see the capsule. I am going below the capsule. I am going below the capsule. Normally why you get the tear? Because you tear anterior capsule while chopping. And then because of that, the posterior capsule is teared. So, and that, why it happens? Because cataract is brown and you will not see the capsule. You will not see the capsule. So always you stain the capsule. Now the stain, you will see how we stain. Our stain is like that. We stain the capsule. Just put a stain and then remove the stain. Always remember, to stain the capsule, it requires 17 seconds. But in the white cataract or in the brown cataract, in the pediatric cataract, the stain should be there for more than 1 minute. Why? It will not only stain, but it will help you for the tear and can say the sear. So both places it will help for the rhexis. That capsule is more fragile. So do it for 1 minute. So the phaco, whenever you are doing, it should give good result and not fast result. So for the good result, you wait, and once you wait, then you can go ahead and do the. So when you are doing the hard cataract, can you see this? I am doing the rhexis. Always remember, when you are doing the rhexis should be larger. Rhexis should be larger. If the rhexis is smaller, then you can't do the phaco. Why? Because the superior portion, that is a anterior capsule is opened, so it will open like this, open like this. If not, then it will be like this and the posterior capsule get teared. Why? Because anterior capsule opening was smaller. The posterior capsule has teared because of the small rhexis. So if the rhexis is small, so increase the rhexis and then go for the phacoemulsification. Otherwise, you will have a posterior capsular tear. So that will be the problem whenever you are doing such type of cataract. And you see this is the cataract and I completed it. So now see, this is a direct chop I am just showing you, and you see the parameters also here. So here you will see I am doing the direct chop. Can you see the tip of this is going inside and then up to the center I am making the piece. See again, my tip is going down and the chopper is separating the. So chop is possible. Chop is possible here. Why? Because there is a whitish element in the cataract. If it is blackish element, stop and chop is better than the chop. So if it is black, don't go for the chop, go for the stop and chop. So that is what is required. Hello. So basically the when such type of you can see it is completed, and can you see this fibrous capsule? Can you see capsule is fibrous, capsule is fibrous, and when see now chopping, can you see this chopping? So here again you will see very slowly I am going inside and making the pieces. It means unless and until you hold the nucleus, don't try to divide. First hold, see here, and once you hold, then take your two instruments on both the sides. So again you will see here, I will show you. Can you see this? So it goes inside, and if it goes inside, then I will make the piece, and once that piece is made, then the I will come out, see here, I will come out, and then it is completed. It means whenever you are doing the phacoemulsification, important thing is that where is your tip is very important. And you see here now, if the tip is in, then your chopper is work. Why? Because this hold will help the chopper to separate it. If it is not hold properly, it will slip. The chopper and nucleus will slip. And so to avoid that, you will have to catch it properly. So this is what. Now this is, you will see the another cataract. Can you see this is completely hypermature cataract? Can you see this? The small nucleus, and you can see the capsule I have stained, but this capsule is having the fibrosis, calcification. And now this, can I do anything? No. Now see what I am doing, I am cutting it, my another, see here, supporting the, see here, I am supported by the, you can say, other instrument, and I am trying to do by the forceps, but it is not happening, I cut it. So I cut it by the scissor. Now what I have done, I have cut the capsule, but as it is a fibrous capsule, and now you will see the nucleus. Are you going to do phaco in this? Never. Never, because this will invite everything. So better if you can go for SICS, go. If not, then you just put a scaffold. Put a scaffold. Before doing anything, when you we put a scaffold, when our fingers are burned, then we put a scaffold. Don't do that. Before finger burn, put a scaffold, and then you see here. And once there is this IOL behind, then it is possible to do the phacoemulsification in such type of cases. So here you will see, so I have completed the phacoemulsification, and the only thing is that whatever works better in your hand, whatever works better in your hand. It is not that I am showing you, so you should do it. No. whatever works better in hand, only you can have a tips from the video. The tips will help you and not my technique. It should be your technique, and the whatever I have shown you is a, you can say this. Ragini madam, as I have to go to the other hall, they are calling me. I will present my another presentation, and that is a IOL exchange. Okay.
Yes, sir. Yes, sir. Please go ahead. Sir, your first talk was very excellent, and you are sure of in different cases. So, what I learned from these all teaching videos, that while dealing with the Morgagnian cataract, you should decrease your intralenticular pressure first before going for the complete rhexis. Use both needle and the forceps to get it complete, or you can take help of forceps to get rid of fibrous capsule. Last piece to be removed with the perpendicular mode, and flap motility sign is very important. If flap is moving upwards, then you are sure that it is not gone toward the posterior capsules. And staining in such cases is really important. You should stain it for a minute, and the sign is, if your side port is got stained, the capsule is stained properly. So, sir, thank you very much, sir.
Thank you. Thank you very much. So, what he told is very true. And now I will show you the few things why this happens. Why this happens? Because whenever you are loading the lens, that time you have made a cataract complete, and after that you feel, yes, I can do anything. And then loading is not proper, and the lens, the one of the loop or haptic breaks. Why? Because you were in the, you can say, so much of the haste, and see, I am cutting the lens. This lens I am cutting, and once the lens is cutting, use visco, because second day patient will be unable to say anything, and then it is very difficult to answer that there is a ear, there is that. So, and now iris is coming out. So, this is going to happen. One complication is supported by other complication. One complication doesn't happen. It happens two complications together. So, like this. So, I have completed it. Now, this is the, I think, patient. This is the patient, the 15 years old patient, having the, can say, -9 myopia, and this patient want to remove of this one, and here, as it was very old, so I have started my old technique of the, they can say this, and here I am trying to separate out the lens. See here, again fibrous lens, going all type of thing going here and there, and lastly I was able to remove. But when I have removed, I have seen there is a PC, tear. So, I have gone to the PMMA lens. This is PMMA lens, one piece. So, we are always concerned with the, can say, bifocal, trifocal, all others. But what is safe is very important. So, I have done the, you can see the vitrectomy also, and I have implanted the lens, which is a monofocal lens, and patient is very happy. It means if the patient was having -9, second day patient is having nothing. So, he can see without a glass, so he is happy. It means it is, he will not ask me monofocal and trifocal. He will say, ki my spect has gone. So, that is what happens whenever you are doing such type of things. Now, another thing is this IOL exchange. See here, I am doing the, can say the 5 minutes में पहुंच रहा हूँ. हाँ. So, now see, I have only loaded, it is not some other person. And what has happened? Can you see this? The haptic is broken. Why? Because I was very confident, I have done everything. And see now, can you see the haptic? So, keep that haptic on the other side. Keep that haptic on the opposite side. And now cut, very small cut is required, very small cut. It is not full cut is required. See here, can you see I have cut the lens very small, and then once you have cut this small cut there, then bring the lens, can you see, loop outside, and I want everybody to see here, rotate it, see here, you can see the cut is there on your side, and I am rotating, can you see this, rotate gradually, so it has stuck near the cornea, and once you rotate, see here, gradually on your right side, you rotate, or if you are lefty on left, can you see, and the lens has come out. I have not extended anything, but small cut that can help you, and then can see this again I will showing you, can you see this, and lens has come out. So it is possible, so broken haptic on that side, and then you cut near the here haptic, and then you bring it gradually by the circle, and it will come out. So this is what conclusion is, IOL exchange can lead to endothelial cell loss, and so whenever such, if you are done the specular count, good, if not, forget. 5 minutes में पहुंच रहा हूँ, ऊपर निकल गया हूँ, 5 minutes. The combination of the cohesive and dispersive visco, so use combination. What is happen? Once you go inside the, you can say anterior chamber with phaco, you tell me how many of you, they come out of the half of the surgery, half remained and put visco. Just raise the hand. How many they come out? 1. So in the 3, 4, 5, 6, 7. Now you can say this hall there may be, you can say more than 300 phaco surgeons. Out of that 9 people are coming out. It means 291 people are not coming out. Why? Because they are in Rajdhani Express. Once they enter, finish. So don't do that. Whenever you are doing a phaco, which is a mature cataract or a nuclear cataract, always, after doing half of the cataract, there should be one break, come out, put visco, and again do it. That will reduce your problems on the second day. Patient will not ask you कि मुझे नहीं दिख रहा है. And so, if you do that, second day your cornea will be transparent and patient is happy. Why? Because just change in one step, that you stopped in between and put the visco. Otherwise that 3 ml visco you are going to throw only. Why not to use? But because we are a very fast surgeon, and secondly we are, you can say the direct, you can say express, so don't be express in phaco. You can say you can have a, you can say small railway like thing where there are so many stations are coming. So be one station, and next time you tell me, you will be very happy on second day. So one station of visco. So half nucleus removed, one station of visco. Whenever you are implanting the nucleus, this lens, see properly, the click sign comes. When it comes, it is inside the, you can say, injector. If it is not coming, then you have just force it, and then you are putting, because of that it has teared. So it means, if you do it properly, it will happen. And I have seen all the people, the new generation, the old generations, they are doing very, very good phaco. So I appreciate the your expertise, and I am very proud of ophthalmologists in India. So they are doing very good work. Thank you very much, and thank you Ragini ma'am for allowing me both the presentations. And now I think you can go ahead with that, and excuse me because there is one OPL going on, and in that I am going to show them some different type of video. Thank you very much. Thank you very much for attending.
Thank you, sir. IOL exchange is not very easy. What we have seen, it is with the experience hand. And most important, what you have shown is a partial cut and remove through the small. This is a very unique idea. Thank you, sir.